My topic is past, present and future of therapeutic innovation in osteoporosis. So osteoporosis, all of you know, is a very common bone disease in human beings. Systematic skeletal disorder characterized by low bone mass with microarchitectural deterioration of bone and a consequent increase in bone fragility and susceptibility to fracture. You can see from this picture that left side there is a normal bone with a thick trabeculae, and the right side it is the osteoporotic bone. The trabeculae are very thin. And the typical comment we get from the people that I have lost 6 inches in height and none of my clothes fit me anymore. That is due to weakness of the weak bones, and there is crumbling and there is a fracture of the multiple vertebrae where the person gets a low height gradually. And osteoporosis has an immense medical impact. Osteoporosis generally does not become clinically apparent until there is any fracture of the vertebra or the collis fracture or the fracture of the neck of the femur. Vertebrae, proximal femur and distal forearm most commonly common fractures are found in osteoporosis. Symptoms are pain, limited range of motion, disability and deformity. And there is hip fractures, 8% to 36% excess mortality within 1 year of this type of injury. And in vertebrae fracture, 4.4-fold increased risk of mortality. And this psychosocial impact on symptoms like depressions and loss of self-esteem as patients grapple with pain, physical limitations and lifestyle and cosmetic changes. Now, in the worldwide, there is a serious health hazard. Like 1 in 1 woman and 1 in 5 men over the age of 50 experience an osteoporotic fracture. A bone breaks due to osteoporosis every 3 seconds. And in India, USA, Japan, estimated 125 million of people with suffering from osteoporosis. Second, it is a second only to the cardiovascular disease as a global healthcare problem. And the annual incidence rate in women is more than combined incidence rates of heart attack and stroke and breast cancer. So it is an immense health problem all over the world. In India, 1 in 8 males and 1 in 3 females suffer from osteoporosis, lower age of peak incidence compared to Western countries by at least 10 to 20 years. Incidence of hip fracture, 1 man is to 1 woman. And in India, basically increase in number of people with osteoporosis due to aging population as life expectancy is growing. As in 2013, it was 10% of the whole population. That was 100 million. Now in 2025, it is predicted that 22%, that is out of 1.4 billion population, estimated to be above the age of 50 years. And what is the pathophysiology? It is basically a balancing act because bone is formed with osteocyte, osteoblast and osteoclast. So in between the osteoblast and osteoclast, the balancing act should be there. Due to the age, estrogen deficiency or other metabolic derangements will lead to increase in osteoclast number and also its activity, a decrease in osteoblast number and its activity. So it will be a combination of the two, leads to bone resorption and which will increase then the bone formation, and which will lead to finally to the osteoporosis. Now there are plenty of causes of osteoporosis. I am not going to the list. And finally, how will you diagnose a case of osteoporosis? From the history, physical examination and bone mineral density assessment, vertebral imaging and biochemical markers of bone turnover. In the physical examination, you can see the elderly patient with a kyphosis at the back, and there is tenderness at the lumbar spine. You cannot get much symptoms till there is any fracture. And now, who defines osteoporosis in terms of bone mineral density? That is dual X-ray absorptiometry measurement of the hip and spine is used to establish or confirm a diagnosis of osteoporosis. There is basically normal bone density is when it is from -1 to +1. If it is less than -1 to -2.5, it is low bone mass. And when the bone density is 2.5 standard deviation or more below the young normal mean, that is T score is equal or less than -2.5. Now, indications for when you will get for a BMD study. When the woman is aged 65 and older, and for men it will be 70 years or more. And younger postmenopausal women in the menopausal transition, and men aged 50 to 69 with clinical risk factors for fractures. Adults who have a fracture at the age of 50, and adults with a condition that is rheumatoid arthritis or taking a medication like glucocorticoids, anticonvulsant, anti-diabetic, those are more prone to osteoporosis. Now, bone mineral density, when the sites you will search for this measurement, that is the neck of the femur, and that is dual X-ray absorptiometry of the hip, you will do at the neck of the femur and the lumbar vertebrae. These two places are the most commonly done. And the biochemical markers of bone turnover, it is bone remodeling occurs throughout the whole life. These chemical markers are mainly which we do not perform commonly in our day-to-day practice. It is not available also in our places. That is C-telopeptide and urinary N-telopeptide. This serum C-telopeptide and urinary N-telopeptide and formation of markers like serum bone-specific alkaline phosphatase, which can be done in our places of practice, and osteocalcin. And evaluating biochemical markers of bone turnover is how will you evaluate, predict risk of fracture independently of bone density in untreated patients, predict rapidity of bone loss in untreated patients, predict extent of fracture risk reduction when repeated after 3 to 6 months of treatment, predict magnitude of bone mineral density increases with current treatment. Now, additional other tests you can perform, that is CT-based absorptiometry, trabecular bone score, peripheral dual energy X-ray absorptiometry. These are all theoretically good but not applicable in our places. The osteoporosis is preventable for both men and women, and management part, there are some general recommendations and there is some pharmacological therapy. Bone health building blocks are basically initially start with calcium, additional with vitamin D, exercise, and prevent the falls to avoid injury, and gain weight, because malnutrition and lean thin body gets more osteoporosis, and stop smoking and control the alcohol intake. So general recommendations are adequate daily calcium and vitamin D3, safe and inexpensive way to reduce fracture risk. Controlled clinical trials demonstrate combination of supplemental calcium and vitamin D reduce risk of fracture. And vitamin D is very much necessary for calcium absorption, because after a certain age, only calcium or the calcium supplement is not adequate. Choose a supplement with vitamin D unless obtaining vitamin D from other sources. Follow age group recommendation, avoid going over a daily combined total 2000 international unit or 50 microgram from food and supplements. And it is not necessary to consume calcium and vitamin D at the same time. You can just take these two in a different schedule timing. And the pharmacologic therapy is anti-resorptive medications and anabolic medications. Anti-resorptives are like biphosphonate, like alendronate, ibandronate, residronate, zolandronic acid. Zolandronic acid is basically, it is an injectable form, and these three are oral form you can prescribe. And calcitonin, estrogen, that is estrogen or hormone therapy, estrogen agonist or antagonist like raloxifene, tissue selective estrogen complex conjugated estrogen or bezodoxifene, and anabolic medications like parathormone, teriparatide. And first line of agents, which is the guideline from the American Association of Clinical Endocrinologists for choosing drugs to treat osteoporosis, are alendronate, residronate, and injectable zolandronic acid. And second line agent is ibandronate. And last line agent is calcitonin, and in between there is a second or third line is raloxifene, which is estrogen receptor antagonist. And patients with very high fracture risk or not responding to biphosphonate, now there is injection teriparatide is now available. And there are some new agents like denosumab, which is fully human monoclonal antibody against receptor activator or nuclear factor kappa B ligand. These are not available. There works are going on this, and this reduced the incidence of vertebral fractures by about 68%, hip fractures by about 40%, and non-vertebral fractures by about 20% over the 3 years. 21.7% gain in lumbar spine bone mineral density and 9.2% gain in the total hip BMD after 10 years of this therapy. And others newer agents, it is not really now the newer agent we are using for last few years, that is strontium ranelate, and which is again the new therapeutic class capable of promoting bones formation. And how does it play? It causes new bone formation and inhibits bone resorption in the same time. So 37% reduction in vertebral fracture and 14% reduction in non-vertebral fractures over 3 years. And long-term registrative trial demonstrate gain in BMD. And the other drugs in the new is in the horizon of osteoporosis is anti-sclerostin antibodies, which is an osteocyte-derived inhibitor of osteoblast action, and thus with inhibition of the sclerostin, bone formation is promoted. And romosozumab, a novel investigational humanized monoclonal antibody, it inhibits sclerostin and has dual effect of promoting bone formation and inhibiting resorption. These drugs are injected subcutaneously once in a month. And in 2016 July to the FDA for the license biological application, it is submitted, and we are waiting for the use in the market. And the next one is the parathormone, which is not in the horizon. It is basically now we are using parathormone, teriparatide. And this is abaloparatide, novel synthetic peptide analog, and self-administered daily subcutaneous injection is and cathepsin is another new drug. There is a cathepsin K inhibitors, major osteoclast-derived proteolytic enzyme in the bone, and degrades type 1 collagen after bone matrix proteins. Studies demonstrate that cathepsin K inhibition increases bone mass and improves the bone microarchitecture and strength. And odanacatab, this is another one of the cathepsin inhibitor. It reduced bone resorption and maintained the bone formation while increasing areal and volumetric bone mineral density and bone strength measured at the hip and spine. And it is also further development on odanocatab stopped due to the risk of some development of the stroke. And so this is all regarding the osteoporosis. Thanks to all of you for your patient hearing.
Thank you very much, sir, for your wonderful insight. Now the session is open for question and answer.
The osteoporosis is a very common problem. I am Dr. Rupam. Here. Osteoporosis is a very common problem. It is mostly common in female compared to the male.
Yes.
And any chance is there is OCP, oral contraceptive pill is responsible for that. And if it is so when these those who are taking OCP, oral contraceptive pill, when they will start the medication for osteoporosis?
I had no idea regarding this relationship between the OCP and the
OCP is estrogen and progesterone.
That causes osteoporosis, but how to prevent that, that is, I don't have any idea. If anybody has any experience regarding that.
Because the 1 in 8 male.
Very common.
And 1 in 3 female, it is osteoporosis is there.
But that is not available in any textbook.
Data is not available.
In the textbook, how to prevent the osteoporosis in a patient who are taking osteoporosis.
It's really a problem of OCP dose and the continuous taking OCP is responsible for osteoporosis. Is there any data is available?
Yeah, there is. But you have to continue. You have to do the conventional sufficient intake of calcium, vitamin D3, and lifestyle change like exercises, etc. Nothing more than that is mentioned.
Other than bone density test, we can regularly prescribe 45 and above. We can regularly prescribe vitamin D or procalcitonin or calcium preparation.
It is already mentioned that for the men above 50 years and the women above 45 years, 1000 milligram of calcium with vitamin D we should prescribe.
Thank you.
There is a small controversy with cardiology in this regard. So people, it has not been discussed very well in cardiology book also. That people come with a coronary angiogram or CT angio report, extensive calcification in the coronary artery. Lean and thin, women or men.
Yeah.
And then they'll say, sir, eto calcium kothai eshe gelo. Abhi to calcium khacchi tai jonne holo. Then I stop immediately. So the next important thing is sometimes osteoporosis and osteoarthritis is not interpreted in the same manner by the patient. So this after I stop taking the calcium, my pain has increased. So it's really a delicate issue. So I just wanted to give my opinion first, then I take your opinions that definitely there is no documentation that you take more calcium and it is going to be deposited in the coronary artery. But if it is there, and patient is taking calcium for a long time, and if we stop it, is there a problem? I mean, at least for few months, and we check that really patient doesn't have any vitamin D or calcium deficiency.
No problem. Also, same thing. People also ask whether due to taking calcium for a prolonged time there is stone in the kidney or not. But if you take the sufficient, if the amount of calcium is taken more than the your scheduled dose, that causes stone in the kidney. It is mentioned in the book, textbook. But regarding the cardiological part, I don't have any idea. Yeah.
And there is no, you mentioned already that it is not mandatory that vitamin D and calcium has to be taken simultaneously.
Not simultaneously means at the same time. But you can just in a space you can take you have to take it in a day. You can put some space. Okay, thank you.
Any other question?
For osteoporotic patients, what is the indication for starting with biphosphonate? Actually, we can give calcium and vitamin D after 45 years of a female and 50 years of male. But when to exactly start? When to exactly start that biphosphonate? Particular any indication?
Biphosphonate usually we don't prescribe most of the people. It is usually prescribed if there is microfracture, stress fracture at the tibia, or there is a collapse at the vertebra. Then for the prevention of further fracture, neck of femur or trochanteric, for any other major fracture to prevent, we can prescribe for biphosphonate. Otherwise, biphosphonate in routine use we don't prescribe.
Any other question? Thank you very much, sir.